disease and prevention. I think I'm doing pretty well at the infectious disease part, not so well at the prevention part. And that's why we're here tonight, to talk a little bit in depth about the current situation with the COVID pandemic, especially with regard to the Omicron variant. So again, I'll ask everybody to mute, please, and we'll continue, and then we'll have some time at the end to take some questions in the chat if people would like to have that opportunity. I want to just mention briefly a little bit about the Simon Clinic Tanzania Project. For the last 21 years, we have been working in East Africa, in northern Tanzania. Originally started out as an HIV project, but of course, it has really just blossomed into a multidisciplinary, very large nonprofit organization, or very large project, a small nonprofit organization, all donors supported. And we've had the opportunity to take over 11 medical teams to northern Tanzania to teach and see patients and perform surgeries and give lectures and expand our horizons and try to bring some of our information to them and take some of the information that they give us home to make the world a better place. So it's been a trying time during this pandemic, but I am happy to report that we are doing very well. We are currently have 5 people in graduate school, 2 in medical school, and 3 in social work school. We have a completely graduated and now attending physician who attended medical school through one of our scholarship programs. That's Dr. Moirana, who's standing right here. And we have had a nursing student complete her studies. So we think that that really is going to be a very substantive contribution to a very underserved area. And I will try to bring in the global aspect of this particular pandemic with specific attention to Tanzania as we move along. So I don't think many of us thought that 2 years into this, we would still be in it. But it speaks to the novelty of this virus. It speaks to the fact that it is a very challenging virus to get under control. And we are certainly and continue to be in a very significant global pandemic. Pandemics have occurred throughout human history with great regularity. In fact, many significant ones have changed the course of history, if you will. In the early parts of the beginning of civilization, there were prehistoric plagues that were well documented in some of the archaeologic and anthropologic evidence. The plague of Athens was an important turning point for the Greek dynasty, and the plague of Rome, which happened during the period of Marcus Aurelius, probably actually brought down the Roman Empire to some degree. Of course, we know quite a bit about the Black Death, which was the bubonic plague that occurred in the 13th and 14th centuries in Europe, and probably infected over 50% of Europe, perhaps killing that many people. Very, very significant pandemic of bacteria, not a virus. And we've, of course, had smaller plagues in the Americas, smallpox, measles, and hemorrhagic viruses, which were significant pathogens, especially in indigenous people. In 1918, of course, the famous H1N1 pandemic, which infected about 500 million people. 50 million people probably died from that pandemic. The 1980s, of course, saw the first pandemic in my lifetime as an infectious disease specialist with the beginning of the HIV pandemic, which, although we have much better treatment now, we still do not have a vaccine for this 100% lethal virus. And 33 million people to this date have lost their lives to HIV/AIDS. Now we are in a very significant pandemic with a different kind of pathogen, another virus, different than HIV, but there are many similarities in terms of how the pandemic is unfolding and some of the tools with which we have the ability to deal with this current pandemic, and I'll describe those as we move along. It's interesting, my career has really been bookended by 2 significant pandemics. I started my career in the late 1980s, early 1990s, when HIV began, also a zoonotic infection like this one, and very, very difficult to control and challenging, and took years to develop testing and the ability to assay viral loads, and certainly the development of significantly helpful medications. That took many, many years for that to unfold. But because of the HIV pandemic and because of what we learned from the HIV pandemic, we have been served well in terms of trying to ramp up our ability to handle this pandemic very, very quickly, in large part due to the many people who were working during the HIV pandemic, and of course the many people who lost their lives. This is perhaps a legacy to them. So this is the statistic this morning from the Johns Hopkins site, just an overwhelming amount of disease still circulating around the world. The estimates for global deaths are around 5.5 million people around the world. That is a gross underestimate because there are many, many millions of deaths that were directly due to COVID that have not been recorded to do that. So it's really a very significant amount and burden of disease. Over 338 million people around the world are currently infected with COVID. Really an impressive pandemic that, of course, has very quickly become a global pandemic in the matter of basically 2 years. Vaccinations are continuing to roll out. The disparity between resourced countries and under-resourced countries remains dramatic. And as we talk about as we move through this lecture, the importance of getting the whole world vaccinated is really at the forefront of our ability to get control of this particular pathogen. So until we can achieve that in at least a better margin than we have right now, even though we have dispensed more than 9 billion doses of vaccine, it's just going to be a really difficult thing to get under control. Recently, this was actually today's statistics from California, and you can see the pattern that we see with these surges. This was the surge last year, which that was probably mostly a Delta, a beta, that was probably mostly an Alpha variant, the 117 that came out of England, high degrees of hospitalization and death. Then we had sort of a lull, and then we had this surge again. This was probably the Delta surge that started happening in the late summer. Delta, much more ferocious than the original Alpha variants that we saw in the last year. But not as infectious as Omicron, which just skyrocketed in terms of the number of cases. And this is the Omicron surge that we're still in right now. And what happens with these surges is they sort of tend to kind of peak, and then they bob around at the top a little bit, and then they eventually go down the other side. That it was a little bit of a slower curve with Delta, in large part because this virus is much more dangerous and has a higher mortality than the Omicron does. Also, we had at this point, people were being vaccinated. The other issue then was with Omicron is the very high amount of virus that we have now circulating. You can see we're sort of at this plateau. We'll probably bob around here for a little bit. This may drop faster simply because people are not as sick with Omicron as they have been with the other variants, although they've been sick enough, and I will talk about that in a little bit. But this is sort of the pattern of these things with these different variants as they emerge and what they do in the populations. This took off like a house of fire. Basically, the beginning of November was the first cases reported in South Africa. Although it probably was circulating globally, one of our significant problems is by the time we identify a variant, it's probably been in the global population for certainly days, if not weeks. And so it takes off very quickly. And that's certainly what happened in Europe and in the United States here in Canada. You'll notice that Africa is sort of down here. That's not because they don't have a significant Omicron problem. It's because they don't test very many people and they don't have a lot of good census of who's got COVID. So it's there, it's significant. It probably did first emerge in South Africa, perhaps, although it could have come from some other country and just happened to land there, and that's where it took off. But it's certainly become a really significant variant as we move forward. Well, I realize that some of you are not infectious disease specialists, perhaps most of you. And so I just wanted to kind of review what a virus is. A virus is a submicroscopic particle of genetic material that's wrapped in this little protein capsule. And this is SARS-CoV-2, the virus that causes COVID-19. Viruses cannot survive on their own. They have to have a host, unlike bacteria, which are multicellular organisms, microscopic, but multicellular, and they can survive on their own. Viruses need to have a host in order to replicate and make more virus. And we certainly know that viruses can cause disease and they can infect plants, animals, and humans. The thing is that viruses also serve a purpose. They are actually part of our normal evolution and can serve a purpose globally in terms of keeping the ecosystem in balance, but they certainly can be pathogens. We know that about 8% of the human genome is comprised of ancient vestigial viruses. Most of these are retroviruses, the same family that HIV is in, but they've become embedded in our genetic material. And that's, of course, occurred over thousands and perhaps millions of years. And so it's a normal dance, if you will, that we do with viruses, that they're part of our normal being, of the normal parts of being human, but they can become pathogens and, of course, cause a great deal of disease among humans and other animals. So let's talk a little bit about SARS-CoV-2, which, as I mentioned, is the pathogen that caused the COVID pandemic. As you know, this is what we call a beta coronavirus. They're called coronaviruses because they have these spikes around the outside of the viral particle. They are common to bats and other animals. There's no question this probably was a zoonotic spillover event. The virus came from animals. They inadvertently infected humans and became adapted to cause disease in humans and found a very nice host to spread more virus. Whether or not there was a concomitant laboratory issue, we don't know for sure, but regardless, it probably did originate from animals. It adapted to attach to the human ACE2 receptor site, which is the significant site of attachment for this virus. It's a highly infectious respiratory pathogen. And of course, we know that it's transmitted largely by droplets and aerosolized particles. And I'll talk a little bit more about that in detail. So here we are. This is where we ended up. These are very familiar scenes to us now. Lots of people wearing masks, the people lining up to get tested, people in the intensive care unit. And then last year at this very time, the presence of what we call our surge tents, when our census at the hospital had skyrocketed to about 204. Right now, the census is running around 100 at the hospital. So we're not having as many individuals that are infected as we did during the time last year, but we certainly have an extraordinarily busy emergency room, and we have an enormous number of patients that we are trying to manage and have had to make some adaptations, as have all hospitals around the country, to handle this surge. I know that most of you are not virologists, but I thought this would be a helpful little video to watch that explains how SARS-CoV-2 attaches to the cell, because it's important when it comes to Omicron, and I'll explain that on the other side.
SARS-CoV-2 is the virus responsible for COVID-19. The surface of the virus is studded with spike proteins, colored teal, membrane proteins, colored yellow, and envelope proteins, colored red. A cross-section shows the viral RNA genome in orange and the nuclear capsid protein, which protects the RNA, in gray. An individual can be infected with SARS-CoV-2 after inhaling airborne viral particles. Upon entering the airways, the virus particles encounter respiratory epithelium cells in the trachea and lungs. The SARS-CoV-2 spike protein recognizes a membrane-bound protein on the surface of the cells known as ACE2, shown here in purple. Once bound to ACE2, the spike protein is unable to open, close, and bend freely, locking it in place. Another cell surface protein called transmembrane protease serine 2, shown here in orange, cuts the spike protein in a specific location. These segments of the spike protein fall away and expose previously hidden parts of the spike. The spike protein can then undergo a series of dramatic conformational changes. During the first stage, the spike protein inserts itself into the cell membrane. Once inserted, the spike protein folds back on itself, pulling the membranes of the cell and virus together so they can fuse. After fusion, the viral RNA is deposited into the host cell, where it hijacks the cell's machinery to produce more virus particles.
Oops. Let's get through this. So basically what happens with Omicron, as opposed to the different variants, that all of these variants attach at the ACE2 receptor site. And Omicron does that very, very well. It has traded infectiousness in for virulence. What it doesn't do very well is merge with the cell. And so that's why we think that Omicron spends most of its time up in the upper respiratory tract. And I'll sort of go through that in a few minutes again. But that's the difference between Omicron and some of the other variants, that it's not as good in that fusion portion of the development of the infectious viruses. The other thing that Omicron can do better than Delta or some of the other variants is that it can evade the neutralizing antibodies, the little molecules that go out there to attack the virus. And that's why we see people that are vaccinated and boosted who become infected. It's quite good at that, but it doesn't do it completely. And so people that do have immunity from the vaccines do better than people that are unvaccinated. But those two characteristics are something very important in understanding why this particular variant has taken off so quickly and why it spread so quickly. It's normal for viruses of this nature to undergo viral evolution. They're always looking for a new host. They're always looking to overcome something that the host does to protect itself. And we saw that with Alpha, which first emerged in September of 2020. Gamma wasn't too much of a player here in the United States. Beta became a little bit of a player in Africa. And then Delta, of course, this last summer and the fall, which turned out to be a very, very virulent virus. And now we have Omicron. So this is a normal progression for viruses. They want to mutate. Most of the time, the mutations that happen during viral replication are not good for the virus. It actually kills the virus. But every once in a while, the mutation that happens may confer an advantage to the virus. It goes, ooh, wait a minute, now I'm stickier. I can attach to those ACE2 receptor sites better and cause more disease. And it's this trade-off between more infectious and more deadly. It doesn't serve a virus to kill its host too quickly. That's why we haven't had really large global pandemics with things like Ebola, because that kills the host very quickly. So a less nasty virus that can kind of sneak around and infect the host without the host knowing, or not make it too sick, is a more selected virus. And perhaps the best one at doing that is HIV. HIV infects people. They usually don't know they're infected, and it can remain dormant for years and years and years. So Omicron is not as good in that department as HIV is, but it is much better at infecting hosts, infecting human hosts than some of the previous viruses. And that's a normal thing that happens in viral evolution. This is the Delta virus. This is the spike protein, the genetic makeup of the spike protein. Omicron has about 50 new mutations. About 43 are contained in the spike protein. So it's really focused on its ability to attach to the human cell. Some of the other mutations occur down here and more of the core protein and may contribute to its ability to avoid the neutralizing antibodies, which we use to fight off infection. So what's that led to? The Omicron variant is much more infectious than previous variants, about 12 times much more infectious. We know that little infected particles of Omicron can remain in the air in aerosolized form and infect people. So unlike Delta or Beta, the previous variants, if you walked into an elevator where someone who had COVID, had Omicron, coughed, there might be some little aerosolized particles that would sort of circulate around there even after that person has left the elevator. So that's something that is important in understanding why this thing is so infectious. We know it attaches vigorously to ACE2 receptor sites, mostly in the nasal pharyngeal, the nose and upper throat. We know that it can avoid neutralizing antibodies, as I've said, but it's not as efficient with the cell fusion portion of the viral cycle, and that may explain why it's a little bit less nasty than, for example, Delta, but it's nasty enough. So this is the R0 value, which is a measure of the level of infectiousness of different kinds of infectious diseases, especially viruses. And this is basically the number of people that can get infected if they have exposure to one sick person. Ebola is not particularly a super infectious thing, but you have to sort of be very close to the person, but it's very bad, obviously. The first COVID-19 SARS-CoV-2 viruses were sort of down here in terms of their infectivity. They had an R0 value of about 1.6. Influenza has an R0 value of about 0.7. The Delta strain was a little more infectious. It had an R0 value of about 4.5. Omicron is way up here at 12, which is almost up to measles. So Omicron is way up here. So Omicron is super infectious, and that's why we just saw it rip through people around the world. It's just a very, very infectious version of COVID-19. So we had this perfect storm. You have a highly infectious respiratory aerosolized virus. It occurs when schools are open, when restaurants are open, people are attending ball games and concerts and going to the movies. Nobody traveled last year for the holidays. It was really kind of a grim holiday season. So everybody was preparing and did travel for these holiday seasons. So global travel was up both during the summer, in the fall, and certainly into the late fall and early winter. The humans around the earth are not very well vaccinated right now. So we really have a large portion of the population of the world that are not vaccinated. And of course you had the holidays. Omicron emerged at exactly the wrong time for us, the right time for the virus. It emerged in November, just before Thanksgiving, just before all the Christmas holidays. And so it just ripped through all those perfect opportunities to spread infection. And within a very short period of time, I mean, just an amazingly short period of time, this variant has now become the dominant virus variant throughout the world. And it's just stunning how fast this thing moved, even in the presence of the vaccines. And we'll talk about what they did. So we have this just enormous amount of disease currently going on around the world and still going on. And it is really an impressive event that happened, a natural event, but something that has really taxed our healthcare systems, and we'll talk about that as well. But again, this is a normal thing for viruses to do, and this has happened to humans throughout our evolution. What we're experiencing right now in 2022 is basically the emergence and evolution and establishment of a new virus, of a SARS-CoV-2 virus. It's laying down basically this layer of disease in our sort of environment and in our fabric of viruses that we now know are human viruses, much like other coronaviruses, which cause the common cold, have done for the last millions of years as humans evolved. And so we are just experiencing the emergence of this brand new virus that is doing it. And it's happening, probably this transition is beginning to happen right about now with the number of people that are infected, but also our ability to try to control it. So you hear infectious disease doctors or experts on COVID talking about the virus becoming endemic rather than pandemic. And this is just a little graphic of what that means. A pandemic is when there's disease spreading throughout the world, it's out of control, it's all over the place, and we are still right now currently in a pandemic. An endemic situation is where there's parts of the world that don't have the disease, that the disease is burned through that, there's immunity, either it's natural immunity or that conferred by vaccines. And so it's not spreading very well, so it's not causing disease within everybody, but there are hotspots around the world. Epidemic disease is when there's a sudden outbreak in one part of the world. We've seen that thing with Zika, for example, or with the occasional outbreak of hantavirus and those sort of things. Those tend to be much smaller. Epidemics can become pandemics. That's what happened with this one. And pandemics can become endemic disease, and that's probably what's going to happen with COVID. This was an interesting poll in Nature that looked at what several immunologists and infectious disease specialists felt was likely to happen. And most of these individuals, and myself included, I wasn't polled, but I will throw in my 2 cents, is that it's very likely that this is going to become what we call an endemic virus. The likelihood that we can cure and get rid of COVID completely in the next few years is very small. I think that window is closing. But it is likely that it's going to establish itself as sort of a normal part of our existence over the next many years. And so we really have to learn how to control it. And that's what we're going to talk about for the rest of the lecture, because we can do that. So first of all, Omicron, I really hear people talk about it's a milder disease. It's no big deal if you get Omicron. People want to have Omicron parties. There was this sort of talk about having parties like you had chickenpox parties. This is not a virus that you want to get. Many, many millions of people have gotten it. Many, many millions of people have had a relatively mild disease. Those tend to be vaccinated, boosted people. But it's not a virus that you want to get. It isn't going to give you any advantage particularly to get it on top of being vaccinated. And we don't know all of the long-term consequences of Omicron, and we can talk about that in a second. So it's a very new virus. We have to be very humble in its presence because we don't know very much about it. And although this particular variant seems not to cause as much death and serious illness as some of the other variants, we still haven't finished this particular surge, and so we don't really know what's going to be happening over the next several weeks. So it is not a virus that you want to get. If you can avoid it, avoid it. If you've gotten it and recovered, that's a good thing, but it is something that we want to pay attention to. This was a retrospective cohort study that was done at Case Western, where I attended medical school. And, it has some problems because it's a retrospective study, but it basically did look at serious illness and hospitalization and death, comparing Omicron with Delta. And it does seem to be not quite as nasty as Delta. It has basically overcome Delta. Most virus now that's circulating, certainly in the United States and Europe, is all Omicron. There's very little Delta left. And so that's a good thing, because maybe it got rid of a really bad player, but we just don't know where Omicron is going to go with this, and we'll talk about that as well. There still are a substantial number of deaths, and that is really something that's just absolutely horrific and a tragedy, that we still have very high death rates, especially in unvaccinated or under-vaccinated individuals. Some of those are people that got one shot, maybe didn't complete the series, maybe didn't get boosted. This is a good reason to get boosted, or did not respond to the vaccines. Many people who have underlying immune problems, certain kinds of cancer, they're on immunosuppressive drugs, they've had an organ transplant, those individuals may not respond to the vaccines, and many of those people, if they get this virus, will die. So it's still a very significant mortality, and that's a statistic that we want to try to control. Even in LA County, and this is something we're going to see this go up, the death rates always go up at the end of the surge, right? People are getting sick, they get hospitalized, they stay in the hospital for 2 or 3 weeks, they're on a ventilator or whatever, then they die. And so the death rates are always kind of trailing along behind, but they are, of course, the most significant and tragic and impactful part of this pandemic. So what is Omicron clinically? Well, it's wildly infectious. We know that it can infect boosted and vaccinated individuals because it can avoid those neutralizing antibodies. We've seen an enormous surge in cases. We have seen a disproportionate number of children now that are hospitalized. Children's Hospital of Los Angeles is full. We've had quite a bit of children passing through our emergency room. Thankfully, most of them don't need to be hospitalized, but some do. Is this because the kids are back in school? Maybe. Although transmission at school is over and over, there's been a lot of studies that have really shown that it is actually not as common as you might think it would be. Is it because kids are largely unvaccinated? That probably is a significant factor. But regardless, there's quite a number of cases now of children being hospitalized. Of course, we have in totality an enormous amount of viral disease right now. So just if children make up a certain proportion, that number is going to be bigger just by virtue of the fact that it's so common. However, Omicron may behave differently in children because it stays up in the nasopharynx and the upper respiratory tract, especially in children. That may be important in terms of their infectiveness and also the clinical disease that they may develop from that. So we just don't know. We're going to have to study this virus more as we move forward, but there are lots of children being hospitalized now, which is a really unpleasant and horrible thing. We also know that it may be dependent on the different populations that the virus is circulating in. In South Africa, they have a largely younger population. There's been a lot of natural disease in that country. And so the surge happened real fast and then it went down real fast. Whether we have that same pattern, we won't know, because the United States and Europe has a largely older population and a lot of comorbidities. We have people that are on immunosuppressive drugs. We have people who have diabetes and hypertension and so forth. And so the virus, this particular variant, may again prove to be different in that group. We don't know whether Omicron will lead to long COVID, or what's also known as post-acute sequelae of COVID-19. This is a very debilitating disease that occurs in anywhere between 10 and 40% of people who've even had relatively mild disease. NPR had a radio show a couple days ago in the afternoon, and there was a physician who said that long COVID was not very common. It was less than 1%, and it was very rare in people who had mild disease. That is not true. We have a long COVID clinic at Huntington, and I can assure you that it can occur in people that have had relatively mild disease. It's a very debilitating, mysterious problem that we're trying to work as quick as we can to understand, but it's a real challenge. And it has an abundance of symptoms that can be very debilitating for people. We don't know whether Omicron can do it. Presumably it can. It does seem to occur more often, long COVID in general, in people who have been unvaccinated. The vaccines do seem to decrease the risk of developing from developing long COVID. And so that may be another reason to get vaccinated. And something that I'm sure all of you are aware of, because it's been in the news every night, is just the enormous pressure that this particular surge has created in the healthcare institutions. These are enormous clinical challenges for healthcare workers who have been doing this all year long, and they are exhausted. We have incredible, incredible nurses and respiratory therapists and EVS people and staff at Huntington Hospital. They are amazing people. Those folks can work out of the back of a Land Rover because I've seen them do it when we're in Tanzania. But it is an enormous challenge right now to keep everybody healthy and to keep them productive so that they can take care of the abundance of patients that we have. That's the difference between this surge and the surge we had last year, is that so many of our staff are also infected. They went on holidays, they saw their families, they are sitting in the middle of this highly infectious soup like the rest of us, and they became infected. And so that has taken a huge number of our people out of the workforce temporarily until they recover and we can get them back to work. But it's affected all levels of community health, both from ambulance drivers to EMT staff to outpatient clinics that serve the underserved, the homeless, the low economic folks have been really impacted by this. Most of those people have been mobilized to try to deal with some of the stuff in the hospitals. The public health department always been understaffed. They are just working 1,000 hours a week, and they are also just as exhausted as the healthcare workers that are trying to deal with this stuff in the hospital. So maternal child care is impaired when you can't open clinics again and get kids in to get regular vaccines in addition to hopefully vaccinating them for COVID. And all of those risks of delay of clinical care lead to the emergence of diseases that are in much more advanced stages. Just before this surge, we were taking care of patients that were very sick from other diseases. They didn't have COVID, but they had advanced cancer or they had advanced heart disease because they had waited. They hadn't gone to their doctor, or they delayed their routine care. And so it really has been a really significant problem for hospitals. And now, of course, we're right now have some of our elective surgeries on hold as we're trying to deal with the massive amount of patients we have with COVID. So it just sort of has this domino effect all the way down the road. And it is a very, very trying time for healthcare in the United States. Now imagine doing this in a country that has really rickety healthcare to begin with. In Tanzania, there is an enormous shortage of nurses, physicians, and clinical officers, lab personnel. Respiratory therapists probably don't even exist over there. There's just an enormous shortage that's occurred over the last decades. In the United States, especially in California, the ratio of one doctor to patient is usually 1 to 400 or so. In Tanzania, it's about 1 to 22,000. That gives you an idea of how few doctors are there in that country to help handle a pandemic of this size. Same thing with nurses. Clinical officers are sort of like PAs. They're not quite physicians, but they're really the backbone of most healthcare in resource-poor countries all over the world. So this has enormous impact in a country that has very limited resources. They don't have ventilators. They barely have oxygen most of the time. They don't have syringes. They certainly don't have access to remdesivir and some of the monoclonal antibodies that we use because they don't even have some basic medications. And of course, they are very much under-vaccinated, and I'll show you those statistics in a second. Very fragile infrastructure, doesn't take much for things just to kind of collapse. And the other piece of this, again, collateral damage from this pandemic, is the fact that most of their HIV/AIDS medications, their medications for tuberculosis and malaria, come from other countries, come from developed countries. They're shipped in. Obviously, with this global pandemic, those medications have been delayed. And so who knows what's happening with HIV, which we have no vaccine for, but this can be very well managed with medications, or tuberculosis and malaria. Those are all significant things that are happening, not in just Tanzania, but throughout the world. So what can we do to try to get this thing under control? Because we're going to have to, and we are doing it, believe it or not. It's just a challenge. So I want to kind of review some of our tools. The most important thing, and perhaps the Achilles heel of this entire pandemic from the beginning, has been testing. And I will say it's disappointing that during this third or fourth surge that we're on now, some countries it's the fifth surge, that we still don't have the testing thing as widely available as it should be. You see these lines around clinics, the lines in the cars, people lining up, not being able to get test results quickly within 24 hours. Even testing kids in school, they get a test in the morning, the test doesn't come back till the next day. So they've been sitting in that classroom and oops, they were positive and infecting other children. So testing is just the Achilles heel and is so important, not only just for right now during a surge, but as we move through this pandemic altogether. There are 3 types of testing that I think it's important to kind of review briefly. The best test, the gold standard, the one that diagnoses the disease, is the nasopharyngeal swab, where we do what's called a PCR. That's called a molecular test. And that can detect active infection, even early active infection when people are not symptomatic. It's highly accurate, about 98% accurate. And in the best circumstances, we at Huntington have a very excellent testing program for our patients and for our staff that we can get test results within about 4 hours. That's really good. Most PCR tests are not that fast. They're often 24 hours, but they're the best test in terms of detecting disease. The antigen tests, which are the kinds of tests that are being used with the rapid tests, test the presence of the actual virus, the infectiousness of the virus. Those can be nasal or throat swabs. And there is emerging data now that, especially with, with Omicron, talking too much, that it might be reasonable to do a saliva test or a throat swab before we do a nasopharyngeal swab. We might detect the presence of Omicron first in that area. And that would be good because that's how antigen tests are done. The positive results are highly accurate. If you have a positive rapid test or an antigen test, you probably have COVID, especially if you are symptomatic. It's not very good at picking up people who are asymptomatic or who have very, very early disease, but it's quick. And you can usually get it within about 15 minutes or an hour. Antibody tests are just tests that look to detect if you have antibodies in your immune system to SARS-CoV-2, whether from past infection or from vaccination. They don't have any place in terms of trying to control a surge or a pandemic. They are a research tool that are very important, however, in assessing kind of the overall immune status of different populations. So this is the nasopharyngeal swab, which I'm sure many of you have experienced, as have I. Very uncomfortable. It doesn't go into the brain. You'll notice patients come out saying, I think they took a biopsy of my brain when they did this, but it doesn't go into the brain, it just goes way up into the nasopharynx. But it requires a swab, it requires transport medium. This is the test that's a PCR. So this is not a very practical test to do in an under-resourced country like Tanzania because it requires a lot of steps and a lot of supplies, many of which they really don't have. Some of the PCR assays now that are being developed are faster, and some of them are tabletop sort of machines that can be run in clinics, so they don't have to have a sophisticated laboratory to do it. This is going to be an area that I think you're going to see more development. I know a few that are attending this lecture are people that are involved in this, and so kudos to you. Keep it coming. We need to have quick, easy PCR assays that can be done even in countries that don't have good electricity. So this will be something that we can really improve on, but it is becoming available now as we move forward. These are the rapid tests. Many of you might be familiar with these. You should become more familiar with them if you've ordered your 4 rapid tests per household by going on the website through the post office. And those hopefully will be deployed in the next few weeks. Better late than never, I suppose. These are fast, they're easy, they are dependent on doing it properly. They can be pretty accurate if somebody is symptomatic. They're not as accurate if you're asymptomatic to detect infected people. They're useful for retesting. So when people are coming out of isolation, they're helpful because they really detect how much active virus you have. The problem with the PCR tests is they're so sensitive they pick up little virus debris, and sometimes they'll have a persistently positive test even though they're no longer infectious. So rapid antigen tests are actually quite good for sort of assessing someone's infectivity. And they're hopefully cheap and hopefully become more abundant than they are right now. But we certainly need to continue to develop novel testing platforms. We have to have something where you line people up, you do something to them, and you get that test instantaneously, accurately, non-invasively, inexpensively, and you can do it repetitively. And this is where some interesting ideas are beginning to emerge. Animals, dogs, bees, cats, reptiles have extremely sensitive olfactory organs. And you can see that dogs are able to sense when somebody's going to have a seizure. They are able to pick up when somebody's infected with COVID. And what they're smelling is the volatile organic compounds, the molecular sort of footprint, if you will, of an infectious disease. It doesn't have to be COVID, it can be other things. Bees, honeybees are very good at this. One could imagine perhaps a large box at the airport after you've passed through the security check. You go into the box with the bees to see if you've got COVID or not. Probably not something that's going to catch on too fast, but it's important to understand that animals already have this ability. And so what we need to do are design devices that can detect volatile organic compounds or other parts of the molecules that are unique to COVID, unique to SARS-CoV-2, and you'll be able to detect all the different variants. That is being worked on. Huntington is involved in a novel program with an outside engineering company. This is something to pay attention to. It could be fantastic if it works. And I think this is really what we're going to have to do, is come up with really novel ways to do quick, easy testing. Especially, you test a child before they go to school. Does Bill have COVID today? Nope, he doesn't. His test is good. Off you go to school. Or you test everybody when they're lining up to go to the movies or to a concert or to a baseball game. Or at the airport, not the bee thing, but the testing breathalyzer test. So those will be very, very important. They could also be used in underserved countries. That would be a huge important event. And they can be perhaps used to detect other diseases, influenza, respiratory syncytial virus, perhaps even non-infectious diseases, cancers and things like that. A really interesting area that keep your eye on. So I want to talk a little bit about isolation versus quarantine, because I think a lot of people are confused about that. This is obviously a group of physicians and nurses that had too much time on their hands. I don't know what hospital they were working at, certainly not ours, but they were able to reproduce the Last Supper. Very important to understand the difference between these two things. Isolation is protecting an individual from others who's already infected. So they've got COVID, they got to go home and stay away from other people. That's isolation. Quarantine is protecting others from somebody who's been exposed. They don't necessarily have the disease, but they had dinner with somebody that tested positive. Now that person is exposed. Now what we're doing is trying to test those individuals, these folks, new things you can do with toilet paper rolls, and you want to test them to see if they have been exposed. But we usually have to wait about 3 to 5 days, because that's when people become symptomatic and express virus. If you test people the next day, that's too soon. So they may have a negative test, then you think they don't have COVID, and off they go and they infect other people. So it's important to understand the difference between these two things, because there are different virologic consequences. Recently, the CDC has decreased its usual 10-day quarantine, which takes about the right time for SARS-CoV-2 to kind of infect the host, be infectious, and then evolve into complete resolution of disease or some other calamity that happens because of the infection. But those people generally are not infectious after 10 days. And you see that CDC shortened those days down to 5 days. They did that for a couple of reasons. It's important to understand what the CDC does. The CDC is not a hospital. They are not clinicians. They're not giving recommendations on how to treat patients or how to treat individual patients. They have to look at the global part of the pandemic, the entire sort of society in its entirety in terms of economic, social, political, mental health, safety, transmission of disease, and clinical disease. So they have a lot of balls in the air. And what you saw happen a few weeks ago when they changed the quarantine issue was they saw this, when Omicron began to spread, huge numbers of workers, flight attendants, pilots, bus drivers, grocery workers, teachers, hospital workers were going out sick, or they were exposed. They were in this group. And so suddenly you had nobody to fly the airplanes or run the hospitals or teach the children or charge up the groceries. And so they had to take a chance and say, okay, we're going to shorten that quarantine period to 5 days. Is that scientifically, virologically the perfect situation? No, because we know that you can still express infected particles of Omicron anywhere between 7 and 9 days after you've been infected. So they've traded off the fact that we have to keep working, we have to keep living, we have to keep functioning through this pandemic by recommending that people stay isolated for 5 days if they're infected, and then for the final 5 days that they wear a high quality mask so that they don't transmit the disease to somebody else. Imperfect, but it keeps society functioning. And that's what the CDC has to do. And that's why they get criticized a lot, because they go back and forth and change their recommendations. But it's always this balance that they're doing for the greater good. Why this topic is controversial, I have no idea. We wear masks for sports. They're kind of macho masks, scary masks, like the hockey mask. We wear masks when we're blowing stuff around the yard. The surgeons wear masks in the operating room. We wear masks on festivals. We put masks on our animals. Even bad guys can wear masks when they rob a bank. But getting people to wear masks during this pandemic has been a challenge, and why there are altercations on airplanes because they have to wear a little piece of paper over their mouth and nose to protect not only themselves and somebody else. It just is beyond me. Wearing a mask protects you, it protects the other person that you're with, and it tells all the people around you that you care about their health. And so it's important right now to be wearing masks when you're out in public. Even if you're walking the dog by yourself, you can take your mask below your nose as long as you're not around people. But when somebody comes by, you put your mask up, and that way you protect them. This virus, this variant is so infectious. There have been cases of transmission outside. And so you need to be very, very careful. And so wearing a mask, it's not that odious a task. It's very important. And this is why, because of the aerosolized issues. SARS-CoV-2 is about 1 micron. That's how big it is. And so it's very easy for it to float around in these little teeny tiny particles when you sneeze or talk or sing or cough. This cloud of goop goes out, and it can be kind of thick stuff up here, and then it peters out down here. But it can go even farther than 6 feet. And these little infected particles that float around out here for a little while can infect other people. And so that's why we want you to wear a mask. And all of these activities can produce droplets, even just breathing. If you're around somebody and you're not masked and they're not masked and you have Omicron, especially if somebody's not vaccinated, even if they are vaccinated, the chances are you're going to get it. It is highly infectious, and it's looking for people who aren't vaccinated. That's what it really wants, is a non-immune host. If you both are wearing surgical masks, perhaps a 3-ply surgical mask, those are the better masks, you really can diminish transmission quite a bit. But there's still this little cloud of gunk kind of floating around here that can infect other people. If you wear an N95 mask, the best mask we have, it's very, very effective at controlling transmission. How do we know that? We know that because last year, none of us were vaccinated. And those of us at the hospital were taking care of patients with COVID. We walked into those rooms with N95s on, and very, very few hospital workers acquired COVID while they were in the hospital during that surge. So N95s protect people, even unvaccinated people, highly effectively. And that's why you sort of hear this recommendation for N95 masks. If you compare them to cloth masks and to surgical masks, they outperform them incredibly. If somebody doesn't have a mask on and you're around them, these are the sort of times that you can be around them and hopefully not get infected. Even in situations, if you're not wearing a mask and they're not wearing a mask, they might be far enough away that you're not going to get infected. But the chances are anything past 15 minutes, you're going to get infected. Cloth masks only help you a little bit. A surgical mask helps you some. N95s help you a lot. If they're wearing a mask, especially if they're wearing an N95 mask, then you can you can be assured that you're probably going to be pretty safe from viral transmission for quite a few hours. This is the situation that you might be in when you take an international airplane flight. And that's why N95s are so helpful on aircraft. Why are they so good? Because they're just sturdier. And these are, you have to get high quality NIOSH N95s that have lot numbers on them, that come from reputable manufacturers. I believe the Biden administration is sending out masks for everybody in the next few weeks as well, N95s. But they're better because they have this, what's called a melt blown layer, which is this fibers that are kind of randomly assigned, and they're much better at catching infected particles as they pass through to your face so that you don't inhale them. They also have hydrostatic properties, and so there's a little bit of electric sort of charge on these because of the way the fibers are arranged and what they're made out of, that actually picks up those particles. And that's why they're so very good at protecting you from not only COVID, but tuberculosis, measles, and so forth. So N95s are really important masks to have in your wardrobe. How do you keep an N95? If you're not going to the hospital like we do, you can reuse them as long as you haven't had a significant contact or contamination. The best way is to take them off when they're clean, put them in a clean, dry paper bag, not a plastic bag, a paper bag, and leave them out for about 3 or 4 days. You can put them in the sun. The heat may help them a little bit. I wouldn't use them more than 3 times because it just starts accumulating a lot of stuff on there. But you can use them more than one sort of event, if you will, by sort of doing these kind of techniques. We need to have better ventilation. This is a sort of a not very much talked about topic, but it's very important. You can do this easily. Open a window, put a fan in the window, have the air going out, and pull the air out. And of course, air filtration with HEPA filters are helpful. This is something really important in schools and kind of neglected. A lot of schools have really terrible ventilation systems, very old systems. And so this is going to be an area where we're really going to have to do some infrastructure changes to improve the safety for children in schools. Our most powerful tool, the vaccines. I'm not going to spend a lot of time on the different types of vaccines. Suffice it to say that the mRNA vaccines are spectacular. They have continued to be amazing and save lives. They are, as I've said before, a penicillin moment. The fact that we were able to develop these vaccines, test them quickly, mobilize them and start using them, they have saved millions of lives. And they are very, very important. They're well tolerated and they are very safe. The adenovirus vaccines, Johnson & Johnson and AstraZeneca, some of the Chinese vaccines and Sputnik V, the Russian vaccine, don't perform quite as well. They've had a lot more sort of problems, especially with the emergence of variants. So the mRNA vaccines are advantageous in those situations. Novavax is a company that's coming out with a new type of vaccine. It's called a protein subunit. We use that with hepatitis B. Vaccines, it does appear that we're going to have at least 3 shots. Right now, we'll talk a little bit about whether we need to have a 4th booster. I think that's probably not going to be very helpful. But the big problem is getting these vaccines around the world, and especially these vaccines. These require a very high cold storage, and so they're very difficult to use in underserved countries. That is something we can get on top of. We have very powerful refrigeration techniques. The Gates Foundation has come up with some good techniques for preserving other types of vaccines. And so I think it is possible to really start using these vaccines, even in places that have not very good electricity, to try to protect people. This shows the benefits of the vaccine. Once again, this surge is allowing us to see how effective the vaccines really are. And you can see this is just in New York, in Seattle, but just enormous difference between those individuals that are vaccinated in terms of who's getting infected, who's getting hospitalized for sure, and who's dying. Big difference between not fully vaccinated. These are maybe people who got 1 shot or maybe even didn't get their booster. And certainly unvaccinated folks are also way up here. And I will tell you that bears out in our hospital as well in terms of severity of illness. So this shows you that even though these vaccines are imperfect with Omicron, they're a little less good than they were with the Delta variant. They are still performing very well, even a few months after we had our last booster for most of us. So I think this just speaks to the power of the mRNA vaccines in particular, and also the importance of vaccines in protecting an abundance of people. Vaccines are not designed to keep you from getting infected. I think people think, well, why I got Omicron, so these vaccines don't work. But you didn't go to the hospital and you didn't die. And that's what vaccines are designed to do. You want to protect the community, keep them out of the hospital, allow the hospitals to remain functional so they can take care of everybody no matter what their disease is. And the only way to really do that is to have good immunity in the community. And so vaccines are the way to go. But you have to have vaccines. And you can see that there's an enormous disparity around the world when it comes to access to vaccines, especially in sub-Saharan Africa. They are perhaps the least vaccinated continent throughout the world. And that is a problem that we're going to have to continue to address very loudly and immediately. Tanzania has a vaccine rate of less than 2.2%, but they have a fairly high burden of disease. You sort of hear this stuff about, well, COVID is not so big a problem in Africa. You know, why is that? Maybe it's because they're younger, or they have exposure to other infectious diseases, or because they're on HIV meds, or because, or for other reasons. The real reason is because they don't have testing. So people just die of some respiratory illness and they probably had COVID and nobody knows it. I can tell you from the physicians that we've trained and that are our colleagues over there, that on the ground, there's a lot of COVID in sub-Saharan Africa and in Tanzania. So they need the vaccines. We need to present them in an equitable way. There's vaccine hesitancy in Africa, just like there is in the United States. But we've got to convince people that they are the best way to protect each other from this really horrendous disease. I wanted to sort of finally talk a little bit about advantages of new types of vaccines. You know, Israel just completed a study looking at a 4th booster with the Pfizer vaccine. I think at a certain point, there's sort of diminishing returns with boosting people constantly. We don't really know whether it make the immune system a little bit kind of, I don't know, here it comes again. And so then when they really encounter the real virus, it doesn't respond appropriately. And so we really need to have vaccines that are either targeted to a highly conserved part of the virus, perhaps the core protein, rather than the spike protein, which is the most mutagenic part of the virus, the part of the virus that changes the most. Or we have to develop a vaccine that could take care of all of the beta coronaviruses. Just because we've got SARS-CoV-2 doesn't mean SARS-CoV-3 is not around the corner, or the alpha coronaviruses, which cause the common cold. And so you heard Dr. Fauci mention this last week, perhaps, about a pan-coronavirus nanoparticle vaccine. Nanoparticles are these little tiny antibodies, and you're probably wondering, why in the world is there a picture of llamas on here? Because llamas have nanoantibodies. And this technology was being looked at to develop a universal and long-lasting influenza vaccine before the COVID pandemic. So I think it's a very interesting and very promising area. The Walter Reed Army Institute of Research is working on it right now as we speak to try to look at the effectiveness of creating a pan-coronavirus vaccine, a vaccine that will hit all the variants, may hit all the potential beta coronaviruses that come along, and perhaps even take care of the alpha coronaviruses, the causes of common cold, and help decrease those kind of problems in our healthcare systems and with our populations. These vaccines induce high levels of antibodies. Perhaps they will be an annual vaccine maybe, or even once every 5 years. So a lot of work needs to go into developing better vaccines that will sort of keep us from having to boost people constantly when many people around the world haven't even gotten the first vaccine. I'm going to briefly talk about therapies because there really still isn't very much. Certainly in individuals who've been hospitalized now with severe COVID, there are very few therapies available. There still is remdesivir, it has some activity. Regeneron, the monoclonal antibodies that we used early on, do not work anymore with the Omicron variant, so they really are kind of a bust. And so we still don't have much to offer people who are well into their illness and are quite sick, requiring hospitalization. There is a new monoclonal antibody that's Omicron specific, and that's satruvimab. It's very expensive. It is a scarce resource. We have about 3 to 4 vials left right now in our hospital. But it is effective in using it very early in a high-risk individual, somebody who's on chemotherapy, somebody who has cancer, someone who has an organ transplant, they get COVID, those folks will do very poorly. This is the drug that can be used to help save them. This is not a drug to treat everybody who has COVID, at least at this point. Maybe down the road it would be, but it's a very, very scarce resource, and so we use it only in those individuals who have a very high risk of progression of disease. Evishield is a 2-part monoclonal antibody cocktail that looks very promising to protect the individuals that we're using satruvimab on. So people who've had organ transplants, people who have CLL or multiple myeloma. This is an intramuscular injection. You give it once every 6 months, and it's quite good at providing antibodies, inducing antibodies to protect these individuals who often don't respond to vaccines from all the different variants, especially Omicron. The game changer that's happened is the advent of oral anti-COVID medications. 2 drugs are currently under emergency use authorization. The first is the Merck drug molnupiravir. Looked really good in its first trial, kind of not so good in its second trial, dropped to about 30% in preventing serious illness and hospitalization. It causes viral mutagenesis. That's how it terminates viral replication. And so for that reason, there's some concern that it could cause birth defects and so cannot be used in pregnant women or people that are thinking about getting pregnant. Paxlovid, however, which is the Pfizer drug, you've heard about it probably by now, looks very good. It is very safe. It is a protease inhibitor based on all of the things that we learned in developing HIV medications. One of the most important HIV medications we have is darunavir, which is a protease inhibitor. And indeed, it's boosted with ritonavir, which is the second part of Paxlovid. Looks very good, has to be used in early disease. It's twice a day for about 5 days, and it reduces the risk of illness and hospitalization by almost 90%. Very important development. Hopefully we can make enough of it that it will be cheap and easy access. And so it really is a game changer in terms of our ability to get this thing under control. It could be used widely. It could be used in resource poor areas if it's made cheaply. There's a lot of sort of litigation going on about patents with this drug right now, but it looks good that that Pfizer is going to make it available. Unfortunately, we also know from the HIV pandemic that monotherapy is not a good idea, that it's very easy for viruses to become resistant. So if we only had Paxlovid, that's going to be a problem. So we really have to develop more oral antivirals so that we can do combination therapy, much like we do with HIV. That really has been a game changer for treating HIV, and it certainly is going to be an important consideration as we move forward for this disease. So we have many strategies that we have. We have many tools that we can use to try to keep this pandemic at least under control, to live with it, to move forward, not to get rid of it. I mean, it would be nice if we got rid of it. Some of us were hoping that Omicron was going to be the grand finale for COVID. I unfortunately don't think that's the case. I think it's just going to be another chapter. But we have many, many more tools. In a very short period of time, we've learned incredible things. We've developed massively effective vaccines that are very safe. We are working quickly on improving our testing capabilities. We have to work just as quickly on policy and equity and making sure that underserved communities, whether it's in our own country or around the world, have access to all of these medications. Nobody is safe until we are all safe with this disease. Omicron proves that on a grand scale. It came out of a country that has some resource issues and spread super quickly around the world. So we have to protect people everywhere and provide them with at least access to at least the basic things that could keep them from getting the disease. We can do this. We landed a little helicopter, Ingenuity, on Mars. How did we do it? Because we did it with, not because this is a nifty little device, we did it because we have the most important tool of all, and that's our brain. And the human brain is designed to take on challenges and come up with solutions. And that's what you see is happening right now in big pharmacy, in the government, in research labs, with clinicians, healthcare workers all around the world, public health individuals. All of those people are working as much as they can to get on top of this thing. Will COVID ever end? It may end. It may just become part of the normal fabric of our lives as we move forward. But we do have the tools to get it under control, and that's going to be a very important thing as we go forward. I don't want to see this New York Times headline because that means we've run out of Greek letters to name the variants. So we just really need to make sure that this may not be the last variant, and I worry about the abundance of replications that's going on, that it may cause the emergence of another variant, but we just have to pay attention to it. So how are we going to do this? What will the new normal look like? We're not going back to the old normal. This is a new normal, hopefully a better normal. The things that we can do right now is, again, monitor what's happening, get genomic testing out there, look for variants before they happen, not after they've happened. The horse is always out of the barn with these variants, and we need to get on top of that better. We need to vaccinate and vaccinate and vaccinate. We've got to keep testing available, cheap, easy, and accurate. We've got to keep the public informed with good science, with good information, and we need to do global outreach to make sure that everybody around the world has access to vaccines and medications. Can we prevent this from happening again? Probably not. This is a natural event that happened. It probably will happen again. Hopefully it won't happen while we're dealing with this particular pandemic with something else, but we need to be prepared. We've got to be vigilant about our supplies, not outsource PPE. Thankfully, that seems to have gotten better, at least in the United States. We need to have early warning systems that something's beginning to circulate. We need to invest in federal and local public health agencies. We've got to have transparent global pathogen monitoring in virology labs. This probably did not come from a lab spill event, but we need to monitor that very carefully because it could have and could still going forward. We need to have global standards for laboratory safety. We have to address climate change, environmental destruction, and animal stewardship. This was a zoonotic spillover event. It came from animals that were normally sequestered away in environments that humans did not go into. With the encroachment of different environments, it allows the opportunity for these viruses to jump species. We've got to provide basic care to everybody. We have to recognize we're a very vulnerable species, and we always, always, always have to follow the science. These are important agencies where we can achieve those kind of things. They're worth looking into and investing in and donating to. And there's thousands of nonprofits just like ours who are working quietly around the world to make our lives safer, healthier, and more equitable. If we do that, then I think we have an opportunity to get on top of this, to move forward, to have COVID just be sort of a thing that happens once a year. We get a vaccine for it, you get a medication if you get the disease. People don't go to the hospital. people don't die, and they are able to live their lives in a much more productive and happy way. These are references and further reading, and now I'd be happy to take some questions that might appear in the chat. Thank you very much for sticking with me here.